Thank you so much, Carlos. I really appreciate the introduction, and I'm honored to be kicking off this virtual symposium and really looking forward to learning from many of the major contributors to this field that are part of this incredible lineup over the next 5 sessions. I have no disclosures, but my work in this area is supported by NIAID, and I will discuss off-label use of medications because there are no on-label FDA-approved therapies for this indication. I wanted to start by thanking the SRNA for putting this conference on, John Hopkins in particular, Carlos Pardo, the KKI, and Christina Stadowski in particular. And I wanted to start by acknowledging the many colleagues who have dedicated their time, expertise, and efforts, often unfunded, to seek answers to the unknowns of this disease. I've just been overwhelmed by the altruism and collaboration between basic scientists, clinicians, clinical researchers, and public health experts, all working together with a common goal. Most of all, I wanted to thank the patients and families who've demonstrated courage and perseverance through the unknowns and challenges of this disease, who have taught us so much through sharing their experiences, and who've selflessly contributed to our knowledge through their participation in research efforts with the sole motivation of helping the next child who could be affected by AFM. In the next 20 minutes or so, I hope to give a 10,000-foot overview of the field, starting from a historical perspective and where we came from over the past 8 years, highlight how far we've come in our current understanding through research advances, and how far we still need to go to combat future waves of this emerging illness. As I said, I want to take you through the 10,000-foot overview of this disease, but I don't want you to forget that every number on every slide, every dot on every map, every box on every graph is a child in a family that has been profoundly affected by this disease. And I hope it'll be a perfect transition from this broad 10,000-foot overview of AFM to be followed by a talk given by Rachel Scott, the mother of Braden, pictured here, who will help us understand AFM at the ground level from the perspective of a parent who's lived this disease for the past several years, and who will also highlight for us the advocacy efforts of a truly incredible community of parents that have come together to support each other and advocate for AFM. Starting with a historical perspective, it's important to remember that while the term acute flaccid myelitis is new, the disease it describes of limb paralysis due to inflammation of the gray matter of the spinal cord is not. In fact, depictions of this disease date as far back as the Egyptian era, with this stele from around 1500 BC of a priest with an atrophic leg, thought to be one of the first documentations of what became referred to as infantile paralysis. We're all aware that poliovirus poliomyelitis became an epidemic in the 1950s, with tens of thousands of cases of paralytic disease per year in the US, prompting creation of poliovirus vaccines, which have effectively eradicated the disease in areas with adequate vaccination programs. It wasn't until these large numbers of poliovirus cases had been wiped away by vaccination that it was realized that other infectious agents, including West Nile virus, Japanese encephalitis virus, and even other enteroviruses in the same family as polio, such as EV71 and EV70, could cause sporadic cases and epidemics of the same disease. In 2012, Drs. Keith Van Haren, Emmanuel Wabant, Carol Glazer, and others at the California Department of Public Health began receiving reports of pediatric patients with a polio-like illness. The CDPH had maintained a passive neurologic surveillance and testing program, but had seen few reports like this in the prior 14 years. They initially reported their findings at the American Association of Neurology annual conference in 2014, a cluster of 5 pediatric cases with a polio-like illness, but who were poliovirus negative, 3 with a preceding respiratory illness, and 2 with Enterovirus D68, an emerging virus in their respiratory specimens. As good scientists would, they followed up on this initial report by setting up a passive surveillance system throughout the state of California for this condition moving forward. Then in the fall of 2014, the same virus isolated from those children with a polio-like illness, Enterovirus D68, caused a widespread epidemic of asthma-like respiratory disease in children throughout North America. As a frontline clinical provider, seeing these patients in the hospital, I can tell you the impact of this virus was unmistakable, with emergency rooms, hospital beds, and pediatric ICUs full of wheezing children due to this emerging virus. It was in the midst of this unprecedented respiratory disease outbreak that unusual cases of neurologic disease also began appearing. This case was one of the first to present to our hospital in Colorado, a previously healthy 18-year-old young man who was on his way to college and developed fever, cough, congestion, and sore throat just thought to be a run-of-the-mill cold initially. But 7 days later, he awoke with headaches, a stiff neck, and noted he was unable to move his left arm. On evaluation, his spinal fluid had signs of inflammation with a CSF pleocytosis, and his neuroimaging showed a longitudinal gray matter lesion in the spinal cord, as well as lesions in his brainstem. Within 24 hours, he was intubated and on a ventilator. He didn't respond to immune globulin treatment and was hospitalized for several months with a tracheostomy tube for breathing and a G-tube for feeding. And his case was not alone. Unfortunately, case after case kept coming into our state and others during this outbreak, at which time state public health departments and the CDC began putting out health alerts for this newly emerging polio-like illness. At the time, there were so many unknowns about this condition. What was causing these unusual illnesses? How was it causing paralysis? Was it a direct infection, a post-infectious inflammatory response, an autoantibody disease? How could we best treat, support, and rehabilitate these patients? And ultimately, what would the future hold with the natural course of disease for these children? In order to investigate a new outbreak of disease, it's necessary to first define what you're looking at from an epidemiologic perspective by creating a clearly defined black and white case definition. It's important to remember that this type of case definition is for the purposes of quantifying cases for surveillance to aid in the investigation of a disease, but it's not the same as diagnostic criteria for clinical care, which allows a more flexible, nuanced approach. And hopefully you'll see soon some diagnostic criteria that the Acute Flaccid Myelitis Working Group has developed that will hopefully be published shortly. So the confirmed epidemiologic surveillance case definition of acute flaccid myelitis since 2014 has contained two major criteria. The first being the acute onset of flaccid limb weakness, which is also known as acute flaccid paralysis, or AFP, which is a broad clinical criteria that could be due to many different infectious and non-infectious mechanisms. This is made more specific by adding a second imaging criteria of an MRI with a spinal cord lesion with predominant gray matter involvement spanning one or more vertebral segments. This modern case definition of acute flaccid myelitis takes the historical term of poliomyelitis, with polios meaning gray, myel meaning marrow referring to the spinal cord, and itis meaning inflammation, or literally translated, inflammation of the gray matter of the spinal cord, which was the autopsy finding in poliovirus cases, and brings it into the modern era of MRI, where we can see transsectionally what is going on in the cord without pathology, and also removes that inherent association with poliovirus, now that we know that several other viruses can lead to the same disease. Studies looking back prior to 2014 show that sporadic AFM cases existed, but that something happened in 2014 when there was a massive increase to 120 cases in 24 states in the US. No one knew what was going to happen after this. Was this a one-time sporadic event, or would it come back? Unfortunately, after a lull in 2015, a second wave of cases during the late summer to early fall of 2016 returned, followed by another lull in 2017, and the largest spike to date in the summer to fall of 2018. You'll hear more about the detailed epidemiology from Dr. Janelle Routh, who's one of the world's experts in the epidemiology of AFM from the CDC. But it's clear that this disease predominantly affects children and is coming in a distinctive seasonal, late summer to early fall, biennial, every other year pattern. The epidemiologic data has demonstrated a strong association between these seasonal biennial spikes in AFM with the periods in which Enterovirus D68 has had peak circulation in the US, making EVD68 the prime suspect driving the AFM outbreak since 2014. You'll hear some new epidemiologic modeling data later from Drs. Brian Grenfeld and Daniel Park, who will be using data on the known circulation of Enterovirus D68 from commercial testing platforms to investigate more granular and geographic and temporal associations with AFM cases and try to model this data to predict future outbreaks of AFM, including potential influences of social distancing occurring due to COVID-19, which I know is a question of a lot of ours. In addition to the US, over 150 cases of AFM or AFP with EVD68 identified have been published from 20 countries on 6 continents, suggesting that this isn't just an American or a North American phenomenon, but truly a global phenomenon, with notable outbreaks reported from Japan in 2015, Europe in 2016, and the UK in 2018. Our understanding of the causal role of enteroviruses in AFM has been strengthened by basic science advances that you will hear summarized later by Drs. Charles Chu and Roberta DiBiase, and directly from many of the basic scientists themselves, but I'll start with some of the highlights here. EBD68 has been demonstrated to be neurotropic, infecting neurons in cell culture in the Schurman laboratory, and motor neurons in astrocytes in a spinal cord splice model in the Rosenfeld laboratory. Drs. Ken Tyler and Allison Hickson have shown that infecting neonatal mice with EBD68 can replicate an AFM-like paralysis, showing the virus infects and kills neurons in the spinal cord, and also separately that the virus can move along a nerve towards the central nervous system in a process known as retrograde axonal transport. One of the biggest mysteries of AFM has been the lack of detection of a pathogen in the spinal fluid of cases. Recently, Drs. Michael Wilson and Ian Lipkin's laboratories have separately come up with ways to look for antibodies in the spinal fluid as evidence of an immune response to a virus that may no longer be present but had been there in the past. Though both labs looked for many different viruses, as you see here, they both found that the only consistently identified viral antibodies were to enteroviruses. This breakthrough not only strengthens the argument that enteroviruses are driving current epidemics, but has the potential to transform the clinical diagnosis of enterovirus-associated AFM cases in which the virus is no longer present in the spinal fluid. Prior to 2014, it was uncommon and almost counterintuitive to look in the respiratory tract of a case of neurologic disease. But this has been found to be the most important site to test for enterovirus D68, which is the most commonly associated pathogen in AFM cases, and as you see here, more likely to be detected if sampling occurs earlier in the course of disease. Likewise, we've learned the importance of looking in other non-sterile sites, such as a stool and the back of the throat, for shedding of other enteroviruses, such as the second most commonly identified virus, Enterovirus 71, which caused an outbreak of AFM in Colorado in 2018. We certainly have learned much about the natural history of the disease by very closely following AFM patients over the last 8 years. I'll give you a broad overview of the timeline here, but you're going to hear much more on the approach to the clinical presentation of AFM from leading neurologists in the field, Drs. Elizabeth Wells, Sarah Hopkins, Leslie Benson, and Ben Greenberg. Most patients start with an acute illness preceding AFM by around a week. Around 90% will involve fever and or respiratory symptoms like cough, congestion, sore throat, some with more asthma-like symptoms. Fewer have GI symptoms like vomiting and diarrhea, seen in around a third of patients, and some cases associated with particular enteroviruses, like Enterovirus 71, may have characteristic hand-foot-mouth lesions on the palms, the soles, and in the back of the throat. Many of these patients will be getting better at the time at which they progress to neurologic disease with the acute onset of neurologic symptoms, with meningeal signs such as headaches, stiff neck, pain in the back, or pain in the limb that is going to go on to become paralyzed. The hallmark of this disease is the acute onset of flaccid weakness during the phase of progressive neurologic injury. Patients rapidly, often over hours, develop hypotonic and hypo or areflexic weakness that tends to be asymmetric, affecting one side of the body more than the other, affects the arms more than the legs, and tends to affect the proximal muscles, such as those of the shoulder girdle, more than the distal muscles in the forearm and the hand. Often underappreciated with this disease is the wide spectrum of severity, from some severe cases with complete quadriparesis to others with mild weakness of a single limb. Around a third of patients will have cranial nerve dysfunction involving the muscles of the eyes, face, or throat, and when this affects the muscles that control the ability to protect the airway, can be one of the most devastating and critical to recognize presentations, as urgent intubation and often tracheostomy is required. Dr. Olwen Murphy will review the neuroradiology of the condition, which evolves over this period from the more diffuse spinal cord edema here, involving the gray matter in the butterfly distribution in the center of the spinal cord, over days to weeks to a more focal anterior longitudinal lesion, localizing to these owl's eyes here, which are the anterior horn cells, where the motor neurons that control the arms and the legs are located. Dr. Matt Elrick will review the electrophysiologic findings on EMG and nerve conduction studies that typically demonstrate a pure motor neuropathy or neuronopathy without sensory findings. And over the next months to years, the long and difficult process of rehabilitation begins. With rehab therapies, Functional improvements are seen in most patients, with the bulk of recovery occurring early, though improvements are noted even a year or more past onset, which is why we stress that early, aggressive, and continued rehabilitation therapies are needed. Huge strides have been made in the rehab of this condition, and you'll hear about many of the advances through experts in the field, including Dr. Joyce Olachek and Christina Sadowski and her colleagues at the Kennedy Krieger Institute. The greatest degree of recovery occurs in those less affected distal muscles, with the more affected proximal muscles showing less recovery. And the muscles that show complete denervation on EMG tend to have persistent paralysis and develop polio-like muscle atrophy, as you can see from these photos of children who are 1 to 2 years after onset. In most series, around 75% of cases continue to have motor deficits 1 year after onset. Fortunately, innovative surgeons such as Drs. Zlotlo and Moore, who you'll hear from in the final session, have had success in some cases with nerve and tendon transplants to restore function in some of these areas that have otherwise not recovered. Though we've come so far in our understanding of AFM, many challenges lay ahead, and we still have so far to go to develop effective ways to treat and prevent this disease. Key to understanding why many children have similar exposures to common infectious agents, but only certain children go on to become affected by AFM, will be understanding the role of the host. Dr. Preeta Gall is leading this charge and will share insight from her studies, which are actively enrolling patients with AFM and their family members to conduct sequencing of their whole genomes. Key to knowing which therapeutic approach, an anti-infective, immunomodulatory, or combined approach, will be most effective is understanding the role of infection versus the immune response in the pathophysiology of disease. Good basic science requires standardized, comprehensive clinical data and the collection of specialized biological specimens, which will now be prospectively conducted through the multi-center NIH-sponsored AFM Natural History study, which we'll hear about from Dr. David Kimberlin, the principal investigator of this new exciting endeavor. We also lack any prospective controlled human clinical trials looking at treatment efficacy in AFM. And I can tell you from personal experience of gathering data from 56 patients treated with AFM in 2016, when we were trying to investigate the effect of fluoxetine as an antiviral, given its in vitro activity against EVD68, just how difficult this can be. In this study, fluoxetine was given at various doses at various timing in half the patients, with nearly all of the patients receiving different combinations of a variety of other therapies, making this type of uncontrolled observational data very messy and quite difficult to make sense of. Unfortunately, thus far, we know more about what doesn't work than what does work in AFM, as fluoxetine unfortunately showed no signal of efficacy, and we've been unable to draw meaningful conclusions about the impact of immunomodulatory therapies such as IVIG, steroids, and plasmapheresis. But there are exciting developments on the horizon. One of the potential mechanisms of IVIG is neutralizing antibody to Enterovirus D68. And researcher Dr. Matt Vogt, who you'll hear from in the third session, has now created monoclonal antibodies with even higher potency at neutralizing virus than IVIG and have shown promise in mouse models, halting progression when given early in the course. Dr. John Modlin and others at the Gates Foundation are supporting the development of antivirals against poliovirus that will be also evaluated against other circulating strains of enteroviruses for activity. And Ken Tyler and others with mouse models are screening various antiviral compounds such as these for efficacy against AFM. Lastly, the NIH Vaccine Research Institute and others are working hard to identify potential enterovirus vaccine candidates in hopes that someday we can prevent the infections that lead to this disease. Key to all of these efforts is early recognition of AFM. I want to end by highlighting the important efforts of the CDC in ramping up outreach and education to ensure that every healthcare provider can recognize AFM. We'll hear much more about the CDC's efforts from Dr. Sarah Kidd later, but to end with a summary of what I hope you will all take home from this symposium. We need providers to think AFM on the differential of any patient with new onset weakness, with a heightened suspicion in children with asymmetric flaccid weakness, with weakness that follows a febrile illness, or particularly during that summer to fall season of enterovirus outbreaks. We need providers to diagnose AFM through a careful exam, MRI, and lumbar puncture, while collecting those early biologic specimens, including respiratory samples, to look for the cause. We need providers to know the basics of how to manage AFM through supportive respiratory, neurologic, and rehabilitation care, while providing expert resources for them to reach out for help, such as neurology and ID colleagues, or the new sRNA physician support portal, which can connect any provider with an AFM specialist for a one-on-one consultation within a day. And lastly, we need every suspected case to be reported to the state health department as soon as it's suspected, so that the requested data and biologic specimens can make it to the CDC and we can continue to find answers to the many questions that remain with AFM. With that, I'll pass the stage over to Rachel Scott, one of the most incredible spokespeople for AFM, to tell her story from her perspective of being a parent of a child with AFM and share with us the amazing community that has risen up to support each other and advocate for AFM through the Acute Flaccid Myelitis Association. Thank you.